This is my curriculum right in disclosure. As if we met like this patient, maybe it looks like very difficult cases, and also so many doctors maybe some thinking about that they need some big surgery or some anterior approach. But if doctors and also the patient all that need hope to some more minimized option to this patient, and not general anesthesia, not the big open and. Because of that, if we can success like this case by the endoscopical, that will be very, very nice to the patient. Actually, the endoscopic transforming reminder or hidden by the posterior approach is very easy to the docking the starting point of the lateral border facet. Then you can see the some lateral border facet, and also in endoscopy movement of fusion, they have a very very big advantage of two the distinct advantage. Well, first is that some chronic adhesive disc drilling make a very excellent disc height restoration like this. And the second advantage is that the end plate denudation, that means that completely preserve the end plate to make a real decreasing so much decreasing the substance and so higher fusion rate like this. And also cage also can safely delivered by the using the Harrison cage glider made by me. And also using like this process, you see like this cases also severe collapse cases. You can, in spite of them, using this chronic adhesive disc drilling technique, you can see the result looks like this. Very excellent restoration of disc height without the anterior approach, only the posterior, only endoscopic approach. And also, fortunately, like this result of the scientific result already published by me, so many paper, like you can see here, the using like the chronic adhesive disc drilling, you can see the excellent disc height restoration, excellent restoration of the spondylolisthesis, excellent correction of the focal segment wedging. Because of that, and also currently, new instrument cage like this large angle cage, especially 16 and 80 degree and 15 millimeter cage can inserted by the posteriorly like this without the open anterior approach. And also in my paper, it already proven that endoscopic movement interval fusion has a more high fusion speed and more low substance rate compared to the conventional open transfer and movement interval fusion. Obviously, some of the cases like this, so severe collapse cases, I already mentioned that using the chronic adhesive disc drilling, this is very easy to restoration without another additional procedures, only some posterior endoscopic lumbal fusion. And also like this, they need some degenerative scoliosis correction cases also. You can see the very excellent correction is possible in the endoscope posterior approach. And also, like this case is a very big surgery case is also very easily managed by the posterior approach without any additional anterior approach like this. And also you can see like this more difficult cases of degenerative failed back surgery cases. In spite of them, this patient also can take excellent correction, only posterior endoscope transforaminal lumbar fusion. And also another cases looks like similar failed back surgery cases also can receive the very excellent correction with the endoscopic lumbar fusion with under the after sedation anesthesia, no general anesthesia, and also because of that nowadays we can easily can apply to the like this degenerative deformity cases also can pass over like this. Because of that, in conclusion, we first see like these cases, and then using the endoscopic transforaminal lumbar interval fusion, you can see like this posterior, immediate posterior OP, and you can see they have only one side decompression. You can make this this steroids restored sufficiently, decompression is sufficiently, and this cartilage restoration, segmental angle, all corrected there completely. And also, this all procedures can pass by the no open surgery, no general anesthesia, no suture, no dressing, no transfusion, no infection. Because of that, nowadays, like this serious cases, not that there is no needed another procedures of enteral approach. Only it can pass by the post endoscopy transforaminal fusion. Thank you for your kind attention.
I
Thank
would
you very
encourage the
much.
speakers, if you have some conflict of interest, like you own or designed a device, that you disclose that in the beginning, please.
Yep.
All right. Thank you very much, Kim, for that masterclass. I think we'll move straight on to Hamid Abbasi from the USA for his talk on Ollif. Please, Hamid,
Good
welcome.
afternoon. Thank you very much. It's an honor to be with you. And just before I start, I was attending the last part of the last conversation about the neuromonitoring, and I couldn't agree more with that, that neuromonitoring is a powerful tool. And the relationship to that, to my talk, is that this kind of surgery can only be done with neuromonitoring. Contrary, where probably more than 80% of the spine surgery, neuromonitoring is an option. In the surgery I'm going to present to you, neuromonitoring is your eyes, your tool, your instrument that keep you safe. I'm assuming I will be able to share my screen. If you don't mind, I'm going to share my screen with you now.
Please go ahead.
Please tell me if when you are able to see my screen.
Yeah, we can see your screen.
And I'm going to slide my slideshow, and I'm going to keep it very concise. I have developed this as a disclosure. I have developed many of these instruments. I have patent. I have a device company, but the talk has nothing to do with the individual device or instrument. It is it's a talk about the actual surgical approach. So number one is what we need to know is the spine is a very widely, very frequently performed procedure. Spinal fusion, as a matter of fact, in the United States is one of the highest performed surgeries, period. Worldwide, according to Lancet and other papers, spine is number one for disability. That is important because in the next 10 years, the number of the people who are going to need or benefit from spinal fusion is going to increase. Now, obviously, we don't treat everything with fusion. As a matter of fact, we don't treat everything with surgery anyways. But considering that by the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem, percentually more people are getting to advanced age, more people will have spine problem, and percentually that number of the people who would benefit or need spinal fusion is going to increase. And this surgery that I'm going to present to you, transcamin OLLIF, is a very efficient way to deal with this condition in certain situations. Now, I want you to understand these numbers are staggering in the United States. I'm telling you that because efficiency would become an issue worldwide. It will matter if you can do 1 surgery, 2 surgery, or 7 surgery in one day. That will change really how we practice spinal fusions. And I want to emphasize again and again, MIS, especially my MIS procedure, is not about the skin incision. It's what happens under the skin that makes this surgery efficient. It's not that we do 6 of those surgeries a day. It's about that 2/3 of them are able to go home same day. All the damage you don't cause under the skin is what's important here. All the muscle that you don't detach, and in a regular spine surgery, even in MIS TLIF, we don't reattach those muscles. We don't, in a MIS muscle sparing surgery, we don't disrupt the autoregulation of the muscle. We don't cut the vascular supply to the muscle. where I taught a regular Tlif, you would go all the way to the lateral gutter, which we would call it lateral gutter, which is practically transverse process. We would go all the way out, pack it with biologic, and we know we'll have to detach all the muscle to go there. Vascularization of the bone is through surrounding muscle, and when you do that, you have reduced the vascularization of the bone to the 25% of the original value. And then that we understand that spine doesn't heal fast. That is the reason. We cause a lot of damage to do that. This is my case in 2012, 2-level Tlif, and you see when we go back 6 months later, it's all scar. 2 years later on this patient, I did the adjacent segment Ollif. In 2016, patient had a car accident. I had to take the patient back. That's how I took this picture, where I did minimal invasive muscle sparing transcamin OLIF. It's pristine tissue, no scarring. And that is why this patient do much better after the surgery. So this is MRI. You see what scar look like. We know how a scar look like in real surgical when we go back there, but that's how it looked like in the MRI. Here you see the scar, and here you see regular muscle, how it should look like. As a matter of fact, this is a patient of mine after the L4-5 Tlif, 2-level above, the multifidus muscle has turned into scar. And these are things that are worth to avoid in your surgery. Now, additionally, efficiency. No surgery is about speed, but this is just a fact. A surgery, if by adding 30 minutes to the time on the anesthesia alone, you are adding 17% to the combined risk of the surgery. So efficiency does matter. If you have any question regarding that, talk to your anesthesiologist. If you put all your surgeries under 2 hours in one group and all your surgeries above 2 hours in the second group, the surgical group with over 2 hours have double the complication rate. In fact, this is based on a meta-analysis of 400,000 patients. And this is everything together. Patients who are prone, that rate is even higher. So obviously, there are many ways of doing the surgery, and I want to make sure everybody understand. I'm not presenting the only way of doing the surgery. I'm just presenting another tool in your toolbox. Each of these surgeries have its own right place to perform. As a matter of fact, this is after 10 years. I think this is my algorithm, how to go about that. I go obviously around the world, I give all these talks and so on, and some people have the misunderstanding that transcamin Ollif is the only thing I do. Well, there are lots of other experts that do other things much better than I do. That's why I don't go and give a talk about the Ollif ATP. By the way, Ollif ATP, if you understand it, the Ollif lateral interbody fusion anterior to psoas. But this is the information I'm giving regarding transcamin oblique lateral posterior lumbar interbody fusion, because I have a lot of data regarding that. Now, there are certainly, each surgery is individually different. Each patient has its own priority. If your priority is lordosis, and some patients, it should be younger patient, they have to live 70 years with that, and so on. The best surgery is anterior or oblique lateral posterior anterior to psoas or direct lateral, because you put a ginormous cage in and you correct the lordosis to a level that nothing else can. If your priority is a direct decompression, you have to do traditional Tlif and Plif. We have done it for so many years. And if you're very good at it as well, you can do it endoscopically or MIS-TLIF. All of that is a possibility. Now, but if your priority is efficiency, I can guarantee you nothing beats the efficiency of transcamin Ollif. Now, obviously we have published papers. As of yesterday, I have done more than 2,053 cases. And this is the statistic of those cases, that 40% of them you can do under 1 hour. And more than 95% of them you can do, I'm talking about multi-level cases, you can do under 2 hours. And this is not specific to me. As a matter of fact, what's very visible in the data that I have gathered over the last 15 years is everybody who goes through the learning curve is become efficient about 5 to 7 times faster than it took me to get at that level. Like it took me about 180 to 200 cases to fall under 1 hour for one level surgery. Everybody who joins us and goes through those steps and add to our learning curve, they fall under an hour for one level fusion in less than 10 to 13 cases. Now, this is, I think, a very important slide that about 380 cases, 1 year, all the cases, spinal fusion in one hospital. And the TLIF, as you see, is the blue line that literally, as makes sense, the time on the anesthesia, time of the surgery increased with BMI. And every
you
other...
need to expedite your talk a bit.
I will show you only 2 more slides after this. And MIS TLIF, as you see at the BMI of 37, it becomes even longer and more risky, whereas the Ollif stays in this study and in the next study with the BMI of to 60 BMI, it stays solid. Now, this is the last picture I want to show you that our patients are ambulating 90 to 96% under 24 hours, and that's why we can send them home, many of them same day. Now, I'm going to stop here. I didn't talk about the technique of the surgery, but there are lots of slides online. On YouTube, you can go there, or you can go to AvicennaSociety.org. There are videos about the technique, how this surgery is done. But if there's any time, I can take some answers. But otherwise, thank you for the opportunity to present this. Thank you very much.
Thank you very much, Hamid Abbasi. That takes us now to Mehdi Dermoul from Tunisia.
Yes, thank you very much.
Nice to see you online.
Nice to see you also, me.
Always a pleasure to have one of our colleagues from North Africa join us. Mehdi, please go ahead.
Thank you very much. Thank you very much. First of all, I would like to thank the organizing committee and especially Professor Salman Sharif and the moderator, Professor Qureshi and Professor Trost. I will share my screen. I will talk about UBE. You see my screen?
Yes, we can see your screen, Mehdi.
I will maybe make it full screen. Okay. UBE is a novel minimal invasive surgery technique which is actually increasingly widely performed due to progressive development of the endoscope and specialized surgical instrument. It shifts the point of visualization away from the surgeon eye or microscope and places it directly at the site of the spine pathology with an endoscope. It allows the visualization of the spinal structure via 2 small incisions on one side of the spine, minimizing tissue injury and enhancing postoperative recovery. Initially, it was used to treat disc herniation, but actually treat a wide range of spine pathology and even spine trauma, but it requires specialized training and instrument and a steep learning curve for beginner. Brief history, this technique started since 19 and the endoscopy started since 19, but this technique started 2 decades ago, and Dr. Son from South Korea developed UBE, which was rapidly growing and popularized in many countries now. And why to do UBE? At least we have 4 goals. The first goal, to reduce muscle dissection and intraoperative bleeding. The second, to reduce postoperative pain and medication consumption. Third goal, to reduce operative time and shorten hospital stay. And the last one, to lower the risk of infection and faster recovery after surgery with less rehabilitation needed. The indication first, it was indicated for lumbar disc prolapse, but the indication was enlarged actually to lumbar stenosis, to cervical pathology and thoracic pathology, and actually even in spinal trauma. Recent article deal with spine trauma with decompressive surgery in thoracolumbar fracture with stenosis of the canal. Here another article dealing with UBE in thoracolumbar burst fracture with secondary spinal stenosis. The technical principle of this technique, UBE utilizes two skin incisions referred further as portal. One portal you make is called the viewing portal and the other is called the working portal. Your non-dominant hand inserts an endoscope and your dominant hand uses the endoscope working portal, and we introduce saline with the endoscope to create a working space. And the saline we will separate the different layer, and we can work without any bleeding. This is one of my patients. The patient is positioned in prone position, and we should draw three landmarks. One medial line, vertical medial line, and a second landmark medial pedicle line, and another horizontal through the space where we will work it. The position of the patient is prone position, and here we use in the same side the endoscope in the non-dominant hand and another incision for the instrument, and the instrument should be triangulated, and the target is the spino-lamina junction, especially in the inferior border of the lamina of the upper vertebra. And we will, after insertion of the saline, we will create a working space. We work in this space, and then we will drill the inferior edge of the lamina of the upper vertebra, and we can do over the top contralateral decompression in case of canal stenosis through one side. And here one of my patients, after positioning the patient in prone position with watertight drapes, we drew the line, the three line, and we should ensure the position of the instrument in the right position by fluoroscopy. And here I show you one of my patient, a 32-year-old male electrician, fall from 2-meter height, causing lumbar trauma, and the patient complaining of low back pain and L5 radicular pain with a visual analog scale of 8, not improved by medical treatment. And you see the plain radiograph, no fracture, but the MRI showed a huge disc prolapse in the L4, L5 space in the right side. We did for him UBE. I show you a small video after entering the instrument here, after exposing the inferior edge of the lamina of L4. We did drilling, and we complete with Kerrison, and we will remove the inner layer of the ligament flavum. You see here the field is very clean, no bleeding, the visualization is good. And we will remove the inner part of the ligamentum flavum to expose the dura, here the dura and the root, and here you see the disc herniation. We will remove this herniation by opening the disc, and by the we will resect the disc by the rongeur, disc rongeur. And finally, we have a good decompression with a root which is free, no problem. And the patient, this is the incision, small incision, and the patient can walk 3 hours after this procedure without any problem, without pain, no lumbar pain, no radicular pain, and he was discharged the same day. The advantage of this technique, it provides a clear surgical field, as you see, donc you said, donc with good visibility, no surgical range limitation with the endoscope by this technique. You see a small incision, less intraoperative bleeding, short operative time, short postoperative stay, fast postoperative recovery, less postoperative complication, and especially low risk of infection and early return to work. And also we can have the cost effectiveness of this technique demonstrated by the fast postoperative recovery and early return to work. And this technique do not need the special instrument. We can use the standard instrument of the spine and no bleeding. The limitation of this technique is the intradural pathology, benign tumor, high-grade listhesis, and also significant dural leak. And the surgeon might have to convert UBE in case of significant dural leak. May have to convert to open surgery, and some author to overcome this problem propose the use of an arm firm which hold the endoscope to carry out practical intradural work and to improvise surgical time using both hands for working. This technique needs learning curve. Learning curve for UBE takes time and requires at least to practice 20 to 30 cases. Step by step, the system can make learning curve shorter. There are complications, but less than the open surgery, dural tear, incomplete decompression, infection, etc. We can avoid this complication for the dural tear. We reduce the water pressure and we repair by patch. The epidural hematoma, we should ensure good hemostasis and control the perioperative of the blood pressure. And if there is migrated lumbar disc herniation, we can adjust the position of the incision according to the position of the herniation. We can shorten also the learning curve. We suggest beginner to choose simple at the first time, simple lumbar disc surgery by the left side approach in early phase, which may reduce the difficulty of practicing. They can apply of 0 degree endoscopy in the early phase, which can make beginner adapt to UBE surgery more quickly. And they should start by drilling the bone and keeping the ligament flavum at last. And additionally, standardized training and practicing on model or cadaver are of great help to shorten the learning curve. In conclusion, UBE is an innovative surgical technique. It is a powerful surgical method for the treatment of lumbar disc prolapse, but also for other disc disease and also for spine trauma. It is more clean than microscope. It is a safe technique and effective alternative for treating various spinal conditions because it reduces pain, faster recovery, and with lower risk of complication. It improves the patient's quality of life, and we can consider it actually as an important advance in the field of spine surgery. And thank you for your attention.
Thank you very much, Mehdi, for that excellent talk. If Nikolai has arrived, we can go to Nikolai.
We're supposed to go to Karina and Basant next, talking about future robotic versus human.
Okay, all right.
So Karina Zigarakis from the US and Basant Misra from India will present.
Wonderful.
Karina, if I destroyed your last name.
Thank you so much, Dr. Trost, for having me. Can you hear me?